The journey of the postgraduate cannot be completed without crossing journal club. So having this in mind, our seniors of Indian Psychiatric Society Tamil Nadu chapter, they have tried to make this process of reading article, understanding the journal easily, so that they have started this particular program, RCBC committee, that is Research Capacity and Building Committee. So to my knowledge, this has been started, initiated by Dr. P.P. Kannan sir, followed by Dr. Vinod, Dr. Ramesh Bhupati, Dr. Neelakandan, and their team members. So they have already made the road, and we are taking that journey to the next level with their blessings. I have to here give some special mention to the seniors, Dr. Neelakandan and Dr. Bevin Satya, who were actively participating in this program last year. They have guided me to improve this presentation. Okay. I also thank the Tamil Nadu IPS President Sir Dr. Sabrin, as well as IPS Cabinet, to accept our team members for this year Tamil Nadu IPC RCBC committee. We have Dr. S.R. Nirmal sir, Professor and Head Dhanalakshmi Srinivasa Medical College. We have Dr. Shivanand Kattimani sir, Professor and Head JIPMER. We have Dr. John Xavier Sugadev sir, from Theni Medical College, Professor and Head. We have Dr. G. Vanishri Madam from Institute of Mental Health. We have Dr. G. Anbalagan sir from Tanjore Medical College. And we have Dr. S. Shankar sir from Salem Medical College. Salem Medical College as our team members. My sincere thanks to Professor Nand Kumar sir, my teacher, for accepting this program. I am very much delighted and glad and blessed to have him as the first presenter of this year Tamil Nadu IPS RCBC. So I invite now, I welcome all the Tamil Nadu IPS cabinet members and extended executive committee as well as extended committee members for this presentation. Now I invite our President, Dr. R. Sabrin sir, for giving his inaugural speech.
Thank you, sir. Good afternoon. It's an honor to be a part of this program. As a postgraduate, most of us seniors will remember that we had very little training in most colleges regarding research, training, and all these things. So that lacune is felt by people who are not in touch with research and training. So Tamil Nadu IPS, our seniors had taken the effort to start this program. So as Sivaram said, almost 5th year we are into this. So, and each year they have improved it and they really worked very hard. And this team, under the leadership of Dr. Sivaraman, is very proactive, and they have started this program even before we could finalize most other things. And the previous batch, Neelakandan sir and others, have really seamlessly handed it over to them. So it's a great opportunity for all of us to learn, and I wish this program all the success. And with these few words, I hand it over to the next speaker. Thank you.
Yeah, good afternoon, sir. Yeah, this is Dr. Shivanand. Thank you for being part of such a wonderful gathering. So let me introduce to the correct speaker, and who is also the whose journal publication is chosen for a presentation. Dr. Nand Kumar. He is a professor of psychiatry at All India Institute of Medical Sciences, New Delhi. He completed his MD in AIIMS and also as a faculty there at AIIMS, Delhi. He is specialized within the psychiatry in neurobiology, neuropsychiatry, and biopsychosocial model of community psychiatry. He is a person who has evolved into biological as well as a social psychiatry. He has been in various official positions and been a member of many academia. So he has served as a sub-dean of exam section in AIIMS Delhi for nearly 4 years. And he has been a chairman currently also from 2019 in the IPS section of physical treatment, also called a Somatic Treatment Committee. And he is a founding president of Registered Neuromodulation Society of India in 2018 for promotion and development of brain modulation technique for research, education, clinical purpose. He has been a founding member and vice chairperson of the National Network of Depression Centers, India chapter, and which is affiliated to USA. He has been a life fellow for Indian Psychiatric Society and Indian Association for Social Psychiatry. He has been on various committees and been a member and expert advisor for various ministries. He has nearly more than 100 index publications and he has been a principal investigator and co-PI for many projects. He has been a guide and co-guide for many dissertations and theses. With this, we will proceed with the next. The article currently chosen for presentation is published from Dr. Professor Nand Kumar. And I request Dr. Kirtana A, who is pursuing her second year postgraduate course in psychiatry at SRMC and RSH, Trichy, to go ahead with her presentation of the journal club. And then the moderators will take over. And I request that if you have any questions, put in the chat box. So all may not be answered. We will try to answer them and we'll compile the questions and we'll get it answers later also. Thank you and request Dr. Kirtana to proceed.
Yes. The topic of my journal presentation today is novel intervention of high-frequency repetitive transcranial magnetic stimulation in patients with somatic symptom disorder and its safety and outcome. My moderators are Dr. Vanishri and Dr. Nimal, and faculty guide is Dr. Shivaram. So the journal was published in Indian Journal of Psychiatry of volume 65, issue 8, published in August 2023. The authors of the journal presentation are Nand Kumar, Prakamya, and Abhishek. Introduction: somatic symptom disorder, which involves persistent physical symptoms like pain and dizziness, accompanied by excessive concern. With a global prevalence of 5 to 7%, somatic symptom disorders significantly impact daily functioning. Yet current treatments, example psychotherapy, CBT, pharmacological methods, are limited and only moderately effective. Transcranial magnetic stimulation, which is a non-invasive brain stimulation technique, is FDA approved for treatment-resistant depression and obsessive-compulsive disorder that also helps in alleviating symptoms of medically unexplained symptoms by targeting specific brain circuits such as anterior cingulate cortex and medial prefrontal cortex. The aim of the study was to explore the safety, feasibility, and outcome of high-frequency TMS using double cone coil at the medial prefrontal cortex in patients with somatic symptom disorder. Methodology: it was a case series, prospective and open label study. Purposive sampling was used, and study population: patients referred from a tertiary care neuromodulation outpatient clinic in view of inadequate response to pharmacotherapy to AIIMS, New Delhi. Inclusion criteria: patients aged between 18 and 60 years, diagnosed with somatic symptom disorder according to DSM-5 criteria by a clinician. Exclusion criteria: those with significant comorbid psychiatric disorders and a history suggestive of seizures, space-occupying brain lesions, or cerebrovascular accident, or having implanted disease and cardiac pacemaker. The validated Hindi version of Patient Health Questionnaire 15, a self-administered instrument, was used to screen patients with somatic symptom disorder. Hamilton rating scale for depression, Hamilton rating scale for anxiety were applied by an independent clinician. Patients continued pharmacotherapy as advised by the treating physician. Primary outcome was to observe change in PHQ 15 questionnaire from baseline to post-intervention. And the secondary outcome was to observe changes in HAM-D and HAM-A scores and subjective improvement in symptoms post-intervention. rTMS protocol, TMS was applied at 15 Hz frequency using the double cone coil at 100% of resting motor threshold. Motor evoked a potential of more than 50 millivolt in tibialis anterior muscle in at least 4 out of 8 trials. The coil was placed 1.5 centimeter anterior to the 1/3 of nascent inion distance with the handle of the coil oriented in sagittal direction along the midline. Patients received 15 sessions of 15 Hz rTMS stimulation with 50 trains of 50 stimuli each and an intertrain interval of 25 seconds. Results: out of 10 patients, 3 females and 7 males aged between 19 and 56 years were enrolled in the study. All patients completed at least 12 out of 15 sessions except one who withdrew consent. The average resting motor threshold was 53.4%. Out of the 9 patients, 8 of them reported subjective improvement in their symptoms, and there was a reduction of at least 33.34% from baseline PHQ-15 scores. At baseline, 8 of 10 patients had HAM-D scores more than 7. 5 out of 10 patients reported HAM-A scores more than 18. 8 of 9 patients reported a reduction in both HAM-D and HAM-A. 1 patient reported vivid dreams following 7 sessions. Another patient reported worsening of headache, depressive symptoms, and suicidal ideations following 15 sessions. So this was the socio-demographic and clinical profile of participants enrolled in the study. This is the comparison of baseline and post-TMS intervention scores on PHQ-12 score of HAM-D and HAM-A scores. Discussion. Patients on medications tended to report greater improvement in their symptoms compared to unmedicated patients. Patients began reporting improvement in their symptoms as early as 15th session. Stimulation of medial prefrontal cortex induced inhibition of ACC activity explains the improvement in somatic symptoms in distress in majority of the patients. Somatization amplification theory. ACC is the critical integrator of cognitive and affective amplifiers of peripheral visceral somatic information, placing it as a potential candidate target area for neuromodulation. Modulation of MPFC is associated with changes not only in ACC activity, but further downstream effects in distal cortical areas mediated either by singular projections or direct effects of coil, which may explain the worsening of depressive symptoms in one patient. Limitations. The treatment effect may have been influenced by other factors related to sampling bias and perceived novelty of the method. Higher baseline scores on HAM-D and HAM-A for patients enrolled in the study, which could be a potential confounding factor. The lack of a comprehensive review of previous medication trials and participants who failed to respond to them may limit the interpretation of the findings in the study. Future directions. The treatment effect may have been influenced by other factors related to sampling bias and the perceived novelty of the method. Further studies are needed to elucidate the validity of this hypothesis that stimulation of MPFC induced inhibition of ACC activity could show improvement in somatic symptoms. Sham control studies evaluating its potential benefit in future lay the ground for larger double-blind sham control trials to rule out the placebo effect. Critical appraisal. Topic significance. The study explores the efficacy of normal intervention targeting the medial prefrontal cortex in treating SSD, which is relevant as current treatments are limited and often ineffective. Research gap. The article highlights the need for new treatment modalities due to the limited efficacy of existing therapies. It also notes that this is the first study to explore rTMS in this specific context, addressing a novel and unexplored area. Study design. The study is a prospective open label case series which is appropriate for early stage exploratory research but has inherent limitations in terms of generalizability and the potential biases. Sample size. The study involved only 10 patients, which is a small sample size and limits the ability to draw broad conclusions. So a larger and randomized control trial would be needed to validate these findings. Selection criteria. The study included patients diagnosed with SSD according to DSM-5 criteria and excluded those with significant comorbid psychiatric conditions. Intervention. So the study applied 15 sessions of 15 Hz TMS using double cone coil with 2,500 pulses per session. So the use of high frequency TMS and the targeting of MPFC are scientifically sound based on previous studies in related conditions, though innovative in somatic symptom disorder. So the outcome measures. Studies used validated scales such as PHQ-12, 15, Hamilton Rating Scale for Depression, and HAM-E. These are appropriate tools for assessing changes in somatic symptoms, depression, and anxiety, which are the relevant outcomes in SSD. Results. Efficacy. The study reports significant improvement in 8 out of 9 patients with a reduction of 33 to 80% in PHQ-15 scores. This suggests that the intervention may be effective, though absence of a control group makes it difficult to rule out the placebo effects of spontaneous remission. Safety. One patient reported significant adverse effects, which raises concern about the safety profile of this intervention. So the report of the adverse effects is critical, but more detailed information would be necessary to fully assess the risk. Strengths of the study. The study introduced a novel intervention for a challenging and often treatment-resistant disorder. So the findings suggest potential benefits and provide a basis for future research. Limitation. The small sample size, the lack of control group, and the open label study design limit the validity of the findings. The results should be interpreted with caution, and further research is needed to confirm these findings in larger randomized studies. Given the study's design and sample size, the findings may not be generalizable to all somatic symptom disorder patients. So the study provides initial evidence that needs to be tested in more diverse and larger populations. Contribution to knowledge. The study contributes to the field by exploring a new treatment. Future research. The article suggests a high-frequency rTMS at MPFC could be a promising treatment for somatic symptom disorder, but it emphasizes the need for further research, including larger trials, to establish efficacy, safety, and longer-term outcomes. Ethical considerations. The study was approved by the ethics committee. And transparency. The open access nature of the article and the detailed reporting of the methodology increases the transparency and reproducibility of the research. So the checklist for case series, critical appraisal tools, which was based on use of JBI systematic reviews. The clear criteria for inclusion in the case series was the condition measured in standard reliable way for all participants included in the case series. Yes. Valid methods used for identification of condition for all participants included in the case series. Yes. Did the case series have consecutive inclusion of participants, which was a bit unclear? Did the case series have complete inclusion of participants? Unclear. Was there clear reporting of the demographics of the participants in the study? Yes. Was there clear reporting of clinical information of participants? Yes. Were the outcomes of follow-up results of cases clearly reported? Yes. Was there clear reporting of the presenting sites, clinic, demographic information? Yes. Was statistical analysis appropriate? Yes. Thank you. That was the end of my presentation.
Thank you, Dr. Keertana. We can move on to the discussion part. Postgraduates from various institutes have logged in. If you have questions, you need clarifications or elaborations on any finer points in the presentation, or you have anything to contribute, you can now put forward your questions. They will be addressed by the speaker. If she has any points to add, she can contribute. Otherwise, we have the expert speaker already present, so sir will address the questions. Okay, so we'll move on to the discussion. Group A, postgraduates from IMH Chennai. If you have questions, you can put forward now.
Good afternoon, ma'am.
Yes, doctor, please go ahead.
Ma'am, I want to know on the 15th session has been fixed on what basis the number of sessions were decided in the study?
Okay. Dr. Keertana, if you have an answer to the question, you can go ahead. Otherwise, sir will be taking the questions.
Yeah, actually, the basis of the basis was not mentioned, but ideally for an rTMS, the standard protocol is based upon ranging between 15 to 30 sessions. So I guess based upon that, the author might have considered.
Thank you for the question. It's a good question. In fact, you know, the 15th session were chosen because of the reason there is no protocol as such, because it's a so innovative area, and there is no study as such. When we published the study and we started using this deep TMS, only one case report was there from Chandigarh, PGI Chandigarh. So there was no idea what to do. So we chose the safest one, 15 sessions. Mostly in what Dr. Kirtana has mentioned also, mostly people try to use 10 session, 15 session, 20 session. That means 3 to 4 weeks. So that was the reason basically. And we also chose the very different area of stimulation. So that was also reason to keep it as lower side as possible. But no, there is no clear-cut guidelines to choose the sessions.
Thank you.
So good
Thank
afternoon,
you, sir. Yeah, yes, doctor.
A study shows that women exhibit higher PHQ-15 scores when compared to men across all age groups. So whether I want to know whether this can lead to any gender-related bias in the study, sir.
Possible, in fact, no, but it was an open label study. So what we did, we collected the cases coming to the OPD. So whatever cases we had, we tried to do the TMS on those cases. So certainly their bias could be there, but no, that's not a selective bias. It happened, in fact. No, whatever patient come to the OPD, we picked up those patients. And commonly, no, in female, the comorbid mood disorders are more common than the men. Most of the study says that.
Thank you, sir. Thank you, sir.
Good afternoon. Sir, good afternoon, sir.
Yes, doctor, go ahead.
Good afternoon, yes.
Sir, we have selected 10 patients for treatment in this study. And one meta review of this SSD shows that this enduring pattern of the patients with enduring somatic symptoms usually do not have, accompanied by anxiety or depression. So in our study, we have taken all the cases with significant HAM-A and HAM-D scores. May I know if it can be generalized or is there?
You are right. In fact, no, the comorbid anxiety and depression were more, in fact. But this was associated with the clinical condition. And the another important thing that what we did was, it was mostly for anxiety and depression, the people stimulate the left DLPFC usually. So middle frontal cortex is not stimulated. So here is the novelty that we try to stimulate the middle frontal cortex. That's much deeper, in fact.
Okay.
But of course, that could be there because once the patient with somatoform disorder comes, and what I think the review we have mentioned is mainly somatoform pain disorder. So these patients are not having somatoform pain disorder only; they were having SSD. So other somatic symptoms are also there. And in non-pain somatoform disorders, the anxiety and depression is, I think, more common.
Okay.
Because of chronicity of the conditions.
Okay, sir. Thank you, sir.
Thank you.
Good afternoon, sir.
Good afternoon.
It's mentioned in the study that patients started showing improvements as early as 5 sessions. All 10 patients who had participated has completed at least 12 sessions. So was there any significant difference in outcomes in comparison to the patients who had completed all 15 sessions?
Not much. In fact, what happens when you give the TMS, the response may start as early as 4 to 5 sessions, or it may last, it may start a little later also. That depends upon the chronicity of the condition, and that also depends upon the patient's profile. So we did not find much difference between those patients who responded at 5th session and those patients who completed 15th session. But no, it's not safe to say that because the samples are just too low. It was an open label study.
Okay, sir.
But what we are doing now, we are having a thesis, MD thesis, for the same clinical condition as a RCT. So we may have some better answer.
Okay, sir. Thank you, sir.
Move on to Trichy SRM. PGs from Trichy SRM.
Good afternoon, Sir,
Yes, doctor, go ahead, please.
That is, it was applied by independent physician, ham A, ham D, and all. Do you think it will be inter-rater variability?
No, the rater was only one, no, because in the OPD, the SR did entire rating. And in fact, the patient, the person who administered the TMS, they were the technician. So they were not aware about this. So no difference in the rating, in fact, in rating persons. So it was one SR in the OPD who did the entire rating.
Okay, sir.
Kumar sir, to the question. This one of the patient has showing worsened in the group. I think it's patient number 4 or 7. I think patient
Yes.
7 participant number 7. There is a showing a worsening of all the scales. So you have explained it, but can you make it little more easy for me to understand what could be the reason for his worsening?
Well, it's difficult to pinpoint the reason. In fact, no, what we had thought of and what we discussed, that since mostly for the depressive protocol or protocol for GAD, we try to stimulate, we try to give the high frequency to the left DLBFC and not in the middle frontal cortex. So that could be one of the reason, in fact, but we are not sure about why they worsen. Because when we try to stimulate one particular area of the brain under the coil, there are a mixture of neurons. It's not a single particular one neural circuitry. It's a mixture of circuitry, and these neural circuitry can be also excitatory or inhibitory. So what kind of neural circuitry we are stimulating, it depends upon that. So the entire concept basically depends on where you are increasing metabolic activity in some part or decreasing it or trying to modulate it. So there could be the possibility that in the middle frontal cortex, there could be the more inhibitory circuitry or more inhibitory neurons or neural pathway, and that can lead to the worsening of symptoms. Because what we have seen clinically, we use high frequency TMS for negative symptom of schizophrenia. In those patients, we have seen the emergence of positive symptoms. In some patients, the depression also worsens. It should improve, but it worsens. And one of the reasons could be, it's not only localized. The stimulation, what we do, it appears that localized, but it also propagates down. And in one of the thesis, what we have observed, that while stimulating the left DLPFC, we had observed the increased metabolism in certain patient in right DLPFC. It should basically not increase, and far below far that area also up to the parietal cortex. So we are not able to explain that. So the only possibility could be that there is better synaptic connectivity between those areas in someone's brain, some particular person's brain. So that could be the reason, but it's difficult to pinpoint, in fact. But these are adverse events, so we need to report it so that people should be careful.
Right, sir. Thank you very much. Sir, a few more, because TMS, we didn't use it much in the JIPMR. So I have a question about this. You said it can be used as inhibitory and also stimulatory. So at what frequency or how it becomes inhibitory and how it can become as a stimulator? That is the first question. And second, when you said tibialis posterior was chosen.
Tibialis anterior.
Anterior, yeah. How will you that the thumb toe moves, or what does it? How will you know that tibialis anterior is stimulated? Yes, thank you, sir.
So inhibitory, that's a very general hypothesis. That low frequency basically that precipitate long-term depression. LTD, that accentuate LTD, so that is inhibitory. And for long-term potentiation, the high frequency do that long-term potentiation, and mostly that is excitatory. So when we see inhibitory, that is basically less than 1 hertz at least, or at least 1 hertz. And when we say excitatory, that means at least more than 5 hertz. So mainly we try to stimulate or inhibit through this. But if you go further and you try to look into the pattern TMS, then the CTBS, continuous theta burst, is inhibitory. just like low frequency. And ITBS is excitatory. That means it can increase the metabolic activity underlying the cortical area. This is the now general broad conception that we follow. Tibialis anterior is basically the leg area is deeper. If you look at the cortical area mapping, in fact, so the thumb area is superficial, leg is deeper, and we cannot stimulate the leg area with the figure of 8 coil because we have to stimulate the deeper part. And this is represented by the tibialis anterior muscles. That means there will be the extensor of the toe area, of the concerned toe area. So we did that, and we have mentioned that also. How did we calculate that? 1/3 of from the distance from the onion to nasion, and little 1.5 centimeter interior. It may vary from 1 centimeter to half centimeter in patient to patient. So you know that we have to move the coil then. Coil first lateral, medial, then little interior. So no, it's not possible to use to stimulate this with figure of 8 coil. When we did this, we did not have the deep coil at that time. So we used that DBT. That's a maximum coil, in fact. And the deeper coil is a concave coil. And concave coil penetrate deeper, it goes deeper. And they claim it goes up to 4 to 5 centimeter. But magnetic field is not as good as we see in the deep TMS. So if we have a concave coil, it can be used like a deep TMS in selected patients.
Thank you, sir.
And
Thank you, sir. Yes, sir, please.
If you use deep TMS, you know that for OC patient, we try to look into the toe area. If you try to calculate the motor threshold, the toe area superficially is being observed. That's tibialis anterior.
Thank you, sir.
Sir, I would like to know about whether there are any variation done in TMS protocol within each participants based upon their duration of illness or previous treatment history. If so done, how it affected the sustainability of their effects?
Sorry, I could not hear properly.
Sir, whether any variation has been done in the TMS protocol within each participants based upon the duration of illness or previous treatment history or age. Any variation has been done?
No, there was no variation done. All the patients received same protocol for same amount of time. So no variation in the protocol. No, similar protocol, similar machine, similar therapist. Therapist means TMS person, the technician who admits the TMS. We call it TMS therapist.
Okay, so I would like to know about the sustainability of the effects obtained from this.
That we did not see that. No, that still we have to look into those patients, these 10-11 patients. So that we have not seen. But of course, now we are doing one thesis, MD thesis on the same clinical condition, and we are putting some follow-up also in that.
Okay, sir. Thank you, sir.
Thank you.
Thank you, sir. Any other postgraduates? You have questions from Madurai Medical College?
Hello, sir. I want to ask a question. In the patients that you have selected, the duration of illness is variable. So whether there is any difference associated with the duration of illness and response rate of rTMS, sir?
In fact, the sample size is too low, so there is no variation as such.
Okay, sir. Thank you, sir.
But no, if we just clinical assumption, if the duration of illness is less, the chances are the improvement will be a little faster. Maybe the patient may respond in 10 sessions, may respond in 5 sessions also.
Okay, sir. Thank you, sir.
Hello, good afternoon, sir.
Yes, doctor, you're audible. Please go ahead.
So in the study, one patient reported worsening of headache after 15 sessions of rTMS. Whether the worsening was adverse of rTMS or worsening of his previous symptom. How to differentiate it?
Yeah, no, it's a good question. In fact, the TMS precipitate headache. No, once you give the TMS,
yes, sir.
Once you give the TMS, there is a scalp muscle contraction, and this scalp muscle contraction may lead to the headache. So mild to moderate headache is not unusual in the patient receiving the TMS. So in some patients, you have to give some painkiller, and the headaches are more common in the beginning. In fact, no, once you start the treatment, the headache is more common. Then subsequently, patient settle down. So it was not part of the basically SSD. It was the mostly TMS precipitated.
Okay, thank you, sir.
Thank you.
Thank you, sir. Thank you for patiently addressing all the questions and dealing with each question with so much of clarity. We will move on to the second part of the session, sir. Welcome you to give your talk on this topic,
Sure.
sir. Thank you, sir.
Thank you. Thank you very much. First of all, no, I'm really very glad and thank you very much for inviting me. In fact, the concept is so good. It's basically State Medical College Grand Round. So entire medical college are getting connected through this academic program. I think it's a very innovative kind of concept. First time I'm looking at this. So thank you, Dr. Shivaraman, for inviting me. Am I audible?
Yes, sir. Yeah, most welcome, sir. Yes, sir. We are very eager to listen to you.
Okay, thank you very much. So I think some part is already covered, and my topic is basically the TMS. It's a neuromodulation technique and the focus on SSD. I will just briefly mention what TMS is. Next slide, please. Next slide. So previous one. So TMS is basically it's a pulse magnetic field. It is just like a magnetic field what MRI machine is having, but MRI machine has a static field and TMS has a pulsating field. So when the pulsating field is there, the pulsating field may generate electricity, and pulsating electricity may generate magnetic field. So basically, TMS is not magnetic pulses that modulate the neurons. It's basically the electrical pulses, but there is no impedance because magnetic magnetic field can penetrate the skull, and there is no impedance, no barrier. So there is no pain, no anesthesia is needed. And I think it's the first painless intervention that psychiatrists have got. And I would say it's a stigma-free because this is the only intervention that we can use at our own self, unlike medication, unlike ECT. So a lot of patients who come for the TMS, they are not uncomfortable. They are comfortable to accept it. But when you offer the patient TMS, they are scared because they equate TMS with the ECT. And they think that it's a shock therapy. So when they see the machine, see the system, and when they see that doctors are also can sit on the system and have the pulses, so the stigma is almost negligible with the TMS. So that's the beauty of the TMS, in fact. Next slide. So this is the TMS machine. This is the TMS machine. Previous one. So you have seen the TMS machine. No, most of you are using also that. So the TMS, basically a lot of machine are there. TMS machine has to be approved. It has to have some standard. And but unfortunately in India, we have a regulator CDSCO under the DCGI, Drug Control Journal of India. And we don't have still regulation on the TMS machine that what we are using. But it has to be have a robust system because the entire TMS effect that depends upon how much magnetic pulses are being generated. And these magnetic pulses, that depends upon how strong the capacitor is of the system. So if the capacitor is very strong, the pulsating pulses would be there. If not, the magnetic field will not be there. That means the stimulation underlying this coil will not be there. So that's important. In India, the data the CDSU is collecting, but they have not come out most likely with the guidelines what TMS machine can be approved till date. So still we are using the FDA guidelines. Okay. The important component of the TMS is the coil, because now with the coil we can stimulate or we can inhibit the underlying cortical area, and the coil is like depending on the coil, we can stimulate either the larger area or a smaller area. We can stimulate the superficial area or deeper area. So for example, if you use circular coil, the larger area can be stimulated. And as I mentioned, the neural network is not very precise, very specific. So if you want to stimulate the larger area, you have to use the circular coil. And if you want to stimulate the very focal small area, then figure of 8 coil is the best coil. If you want to go deeper, because the penetration of this figure of 8 coil is hardly 0.5 to 1 centimeter. But if you want to penetrate the deeper cortical area, then we have to use the double cone coil or the concave coil. So the coil depends upon what kind of area you are going to stimulate. And it is always a good idea to have at least 1-2 set of coils. Say, for example, figure 8 coil and double cone coil. Or if not double cone, then maybe the circular coil. And that also depends what kind of work basically you want to do with the TMS. And recently some other coil also has come up, like H1 coil, that is a helmet shaped coil. And these coils, the H1 coils, H coils, they stimulate the larger area, unlike the figure 8 coil, or unlike this double cone coil also. That means the larger cortical area is stimulated with this both H1 coil in different cortical area. Now, the coil are becoming very expensive, in fact, because the entire the TMS business, the outcome business, that depends on the coil, and the coil cost is very expensive in the recent machines. So for deep coil, then if you go by the deep H coil, it is very expensive. It costs about 15-20 lakhs only for the coil, or at least 15-20 lakhs. And if you are treating 2-3 conditions, suppose if you are using the deep coil for depression, we have to use the H1 coil. For OCD, H7 coil. So you have to change the coil. And for smoking cessation, then we have to use different coil. So that takes TMS to a different level in terms of the expenses. So now what they're doing, in fact, they're trying to develop a coil in which there could be the different configuration, the same coil, and perhaps that may take some time, that may come to the market in the next 10 years. So with the coil, we can have a different kind of stimulation, like a deep coil. As a less focal stimulation, we can go much deeper. Theta burst stimulation, we can use the deep coil also. We can use that figure of 8 coil also. And in the theta burst, it is for shorter than traditional TMS. So when we started TMS in 2011-12, at that time only TMS that was a conventional was available, and you could treat only 5 to 7 patients maximum per day. But with the theta burst, with the same effectiveness, we can treat much more patients in comparison to the TMS than the conventional TMS. That means we can treat at least 3 times more patients, because the theta burst takes for typical depressive protocol 3 minutes, and the TMS, that is the conventional TMS, that takes about 25 minutes or 17 minutes. So there is a difference, in fact. Then it's as I mentioned, it's basically expertise. Suppose some patient is not responding with the theta burst TMS or deep coil TMS. So what you do? You can say that it's not working. But here the uses something just like a medication. Like you use different kind of permutation combination in terms of pharmacotherapy. Same thing is being done with the TMS also. Say, for example, if some patient is not responding, then we can do the priming of cortical area. Priming in the sense like, in some patient, if they're not responding, if we can inhibit the right cortical area, right prefrontal cortical area, we can give low frequency. So if low frequency is given to the right prefrontal cortex area, so that will be the stimulatory for the left side. So that simply means okay, left is more prime now. And if you give the high frequency after the priming, the effect may be better. And there people have studied that also. And the response rate is up to, if they compare it, the response is up to 40% versus 8%. So there is a huge response. But that depends, what kind of patient you are choosing and what kind of priming you are using, something like that. Then there is a simple TMS also. So multiple TMS protocols are there, just like medication. If you have the knowledge of the TMS system, you can use those protocols just like medication. We briefly discussed about the high frequency, low frequency. High frequency means it could be pattern pulse also. Low frequency means single pulses. The frequency is less than 5 Hz, mostly 1 Hz or less than that. Then there is a pattern TMS. Pattern means either intermittent theta burst or continuous theta burst. In intermittent theta burst, there is a burst of pulses, say burst of 50 Hz pulses at the background of 5 Hz. And in the beginning, it was not considered safe because 50 Hz is too high. But it is a burst of pulses, but very short pulses, not more than 5 pulses, in fact, no per burst. And it was safe. And I think in 2018, it was approved by the FDA for treatment of depressive disorder. So the number of pulses are 600 to 900 in the theta burst. Then continuous theta burst, that is for inhibition. If you want to inhibit the cortical area, then use the continuous theta burst, just like a low frequency. And the pulses are almost same. Now, we can have the modulation of the effect by changing these pulses per session. And by also increasing or decreasing the pulse density. That simply means instead of 3, we can think about 4. But of course, safety concern is there. And we have done that, in fact. And that also lead to the different in the outcome. So multiple pulses are there, just like doses of medication. Next. So this is the way that TMS we do. We can stimulate any area. Here, typically it is a thumb area or the brain. Thumb area is usually 5 centimeter anterior to the it's a DLPFC area basically, and DLPFC is mostly 5 centimeter anterior to the thumb area. And there are some mechanism to measure that area. We can use it manually also, and we can use it with the help of neuronavigation also. And this is the TMS coil. It's a basically ear thin film coil. Next. So this is what happened when we give the TMS. You can see the coil. So the TMS has the effect at 2 levels. One is the local level. So once you give the TMS, either high or low frequency, there is a local modulation of neurotransmitters. So at this particular area, if the high frequency is being used, these local neurons are being depolarized. And subsequently, not only this, the deeper structure, because that pyramidal neurons go deeper. So once some mixture of neuron is getting depolarized here, those neurons going deeper, they can stimulate the area lying deep in the cortex also. Just click one more. Just have a single more click. So it is something like this. The depolarization of pyramidal neurons also causes the neurotransmitter release in the deeper brain area, just like this line. So it is not that this area is being activated. Like one question was there in the previous discussion. So this also activate the deeper neurons. And as you know that there is closed loop neural circuitry. It's not that one neuron. So this deeper neuron, when this get activated, it's also activate the adjacent neural circuitry. And activation of deeper brain neurons, then it may exert secondary effect on remaining portion of the targeted mood circuit. And so this whole circuit is being activated. So there is some effect on the local area and some effect on the deeper area. That depends how this neural circuitry is connected from the deeper area or other area. And but there could be stimulation here also that we don't know, in fact. No, if that depends upon the connectivity. And if you stimulate this area, then the local area is stimulated, DLPFC. Then if it goes deeper, then there is a deeper stimulation, and that may go up to the anterior cingulate cortex. But for that, you need to have a little high power coil with a deeper stimulation property. Next. So once there is a change in the metabolic activity, this metabolic activity changes may lead to the release of neurotransmitter of the related with the concerned particular part of the neural pathway. And that could be dopamine also, that could be also serotonin. That depends what circuitry is being activated. And these effects are associated with the improvement in the depressive symptoms or any other symptoms. Say, for example, if you are using the low frequency here instead of high frequency, the patient of mania may be improved. Or if you use low frequency in patient with depression, the patient may be further depressed. So what you are using, why you are using, and where you are using the location, that is very, very important to have the effect of the TMS. Next, please. Next. So roles in psychiatric disorder. We all know that in depression, it is approved in 2008. And in the beginning, it was no TMS, that was a conventional. Now it is deep TMS. And all three protocols are approved. Next, like conventional protocol approved, it takes about 20 minutes. Theta Burst protocol, some people call it express TMS. That takes about 3 to 4 minutes. And deep TMS, 20 minutes. Now, mostly people are trying to use this deep TMS. But deep TMS has different, of course, it's more effective. But it's a little expensive. Plus, treatment duration varies. Like for 4 weeks is needed as per the FDA protocol for non-deep TMS or TMS that is a conventional coil or ITBS. But with deep, it is much more longer. And with TMS, one problem is there. The patient has to come to the clinic. So it's unlike pharmacotherapy. In the pharmacotherapy, you have prescribed the medication, patient has gone, and the patient can come after 4 weeks or 6 weeks. Here, the patient has to come daily for 5 days. 5 days in a week for 20 sessions. That means patient is bound to come, and it takes approximately 10-20 minutes for the lab to administer the TMS. So the protocol is very important. What kind of protocol you're using for the TMS and what frequency of stimulation you are using. If the patient need or the protocol says 20 Hz, if you take extra caution, and if you use 10 Hz, the effect will not be there. If you use the high frequency, the patient may develop seizures. So it's good to stick to the protocol as much as possible. And if the patient does not respond, then you can try a lot of permutation, combination, sequential protocols, so many protocols. So once we're aware about different protocols, we can have the better result. So this I was trying to convey in the just 1 minute back. So when the sequential protocol was used and it was compared with the sham, the response was 44% versus 8% in sham. It's a huge, huge difference, in fact. Their study, I don't think the follow-up is there, but that simply suggests that before saying no, it doesn't work, we may perhaps explore further, but the cost is there, and we have to tailor that cost carefully. Next. Then Theta Burst TMS, that I have mentioned, it takes much less time. It's a safer also. The effect is faster and more intense. And this is also approved by the FDA for treatment of depression. That was in 2018. Next. Deep TMS. Deep TMS takes no much more time. In fact, if you look at the protocol of deep TMS, for 4 weeks, we have to use 5 sessions per day. That means 20 sessions. Then they says the continuation phase, week 5, week 6. So 2 treatment per week. That means 10 to 16 treatment. And that is 4 to 6 weeks. So it is up to almost 12 weeks. But there is a problem, no? In non-deep TMS, what we are using, we are seeing the good result. But in deep TMS, the results are definitely better in some patient who did not respond to the non-deep TMS figure of 8 coil. They responded to the deep TMS. But treatment duration is quite longer. What clinically we have seen, and clinically we follow also, like if the patient respond, previous one please. If the patient responds, say for example in 5 sessions, and the patient is symptom free, although the protocols say that no, extend this up to the 12 session, 20 session, but it is safer not to go beyond that, because you are not actually knowing that it may lead to the overstimulation of that cortical area, or may lead to the adverse event, or may precipitate some switch phenomena. So it's always better to have the regular sort of observation of the patient, at least weekly. So it should not be like this, that 20 sessions ke baad I will see the patient. It's not like that. So it's well established. There is no doubt about that. People are using it globally, and this is the perhaps first kind of psychiatric intervention where the money is being invested by the person who have the business interest also. And we know the several TMS centers are there in Delhi also and in India also. Next. Then schizophrenia, no, it is being explored very aggressively. Of course, it is effective, what Dr. Vanishri has mentioned, for auditory hallucination. And it is also effective for negative symptom. But there is no robust data. But data are being collected now, and the last 5 years, a lot of studies has come up. And we have 2 studies, in fact. One was in deep TMS. One was in deep TMS. One was by TMS, conventional TMS, and one by the ITBS, Theta Burst. And we observed a positive outcome in our patient in negative symptom. Of course, auditory hallucination, some patient response is very good, especially those patients who don't respond to medications. And auditory hallucination and tinnitus, the ENT condition, they are almost similar neurophysiologically. So same protocol also is effective in some patient in the tinnitus, and we have used those patients. So for schizophrenia, auditory hallucination is good, but not approved by the FDA. For negative symptoms, it is being used and it is effective, but FDA approval is not there, but it is likely to be there perhaps within few months. Next. And the hypothesis on which we work on this negative symptom schizophrenia is this. We assume that there is a hyperfrontality in the negative symptom pathogenesis. And these hyperfrontality can improve with the brain stimulation technique like the TMS, or maybe other technique also. And TMS has shown to reverse this hyperfrontality, and the positive effect could be because of that. Next. Next. So this is our study about what we have done in 100 patients. When this study got published, at them, it had a higher sample size. And in this study, we had a follow-up of 4 months. And the effect of the improvement in the negative symptoms, anhedonia, elogia, evolution, attention, impairment, the effect was sustained for up to 4 months. And some patient also maintained the response up to 6 to 7 months and up to 8 months also. So we are looking at those data, in fact, because these patients are coming for the follow-up. So that means the effect are sustained. There is no doubt about that. And we ruled out depression in these patients through collective depression rating scales. Next. So for negative symptom, we are using in our lab the high frequency TMS, left DLPFC area. And for auditory hallucination, we are using the low frequency TMS between T3 and P3. But of course, FDA approval is not there because evidences are still contradictory. But now the more robust data is available. So let us see what happens. Next. Then OCD comes. In OCD, we had very good exploration, in fact. Now it is approved with the deep TMS, but that does not mean if we are not having the deep TMS, we can't treat OCD with the figure of 8 coil. And in our experience, next, in our experience, the person, most of the patient with OCD, there is a issue, hyperactivity in the OPC area or supplementary motor area. So most of the patient respond when we try to stimulate this area. And some patient respond with supplementary motor area stimulation, and some patient respond with the orbitofrontal cortical area stimulation. And we have tried this and the result was good, in fact. But now FDA has approved this deep TMS. So deep TMS is being used mostly for the OCD. But even if you don't have deep TMS, we can do that. But again here, the treatment duration is very, very lengthy as per the FDA protocol. So for week 6, you have to give the 5 sessions per day. Then subsequently, you have to again use further treatment for some sort of maintaining it or better outcome. And they also use provocation administration. That means the patient is encouraged to have the more intense symptom for the OC. But this is very much distressing. In fact, most of the patients don't like it. And the data says, the lot of data is there that it is effective. But protocol, of course, it takes very, very long time. So we have started using deep TMS recently, in fact. So we don't have much experience with this. But with our earlier figure of 8 coil, we have a good experience and it works. And the effect lasts for again 3 to 4 months. So only deep TMS is recommended for the OCD, not the other coils. Next. So SSD. So SSD, as the doctor has presented very nicely, in fact. And there is no much treatment for this SSD. So the treatment is not available. It is good to explore for some sort of treatment that is innovative treatment. And that was the reason we tried to venture into this clinical condition. Next. Symptoms, we all are aware. It's basically group of symptoms like dizziness, abdominal pain, discomfort, nausea, palpitation, headache, and so on. Next. So the current treatment option is almost limited, and treatment of choice is mostly psychodynamic psychotherapy or CBT. And we all know that how much it works, and the patient always asks for some kind of treatment. And the effect size of treatment or pharmacological treatment is not good. In fact, it's low. So next. The comorbid depression and anxiety is high, in fact, in SSD because of chronicity of the condition. And outcome also depends upon that. And if you look at the DSM, the outcome depends also on total number of bodily symptoms. And the change in the SSD in the DSM-5 is, like, even if I have a established medical condition, but still we can diagnose the somatic symptom disorder. Unlike earlier, that we have to rule out the medical condition. That means there is always a psychological overlay. There is always some sort of different kind of perception and interpretation in different neural pathway, neural circuitry. So in the next slide, we'll try to understand somatosensory amplification. Next, please. So this is this is being proposed by the Mayo et al. So etiological model. So if we just think very simply that one stimulus can have different kind of effect on our body, like same stimulus will have different kind of effect in my body, and same stimulus will have different effect on your body, and that depends upon how it is configured, how the stimulus is perceived from the somatic sensation, and how our neural pathway, neural circuitry is pre-established, and how it is conditioned from the beginning. So any somatic sensation arising from any process, either physiological, pathological, or environmental, or inner or outer, external, interior, any that depends on how it is getting interpreted. And this interpretation of somatic sensation and that depends upon what sort of makeup or configuration or neural pathway we have. And the lot of factor is being played by some circuitry that is involved in the emotional arousal. Say, for example, angular cortex, say, for example, the insula. And if these are overactive, then more arousal is there. And if the more arousal is there, the interpretation will be different. Either it will be very high or it will be ignored. And of course, that is also having association with the knowledge base experience of the self, family, others, and the same experience of the same condition in the past. So previous one. So then now other factors, what we were trying to discuss. If the person becomes chronically having some issue with these somatic symptoms, and even with medical condition also, then the comorbid depression and anxiety comes up, and that also help to maintain somatic symptoms for a long time. And since multiple area is involved, and the patient may respond with the larger area stimulation, because still the studies are very, very less, because the PET and SPECT studies are very less in this kind of clinical condition. And this is one of the area that we need to perhaps look into this, either by fMRI or PET studies, what area are being engaged, so that we can have a better localization for the stimulation. Next. So amplification, she tried to mention in the presentation, like cognitive amplifier, then affective modifier. But for the practice of TMS, we focus more on the aberrant circuitry in the neural system that mediate the visceral somatic perception and emotional processing, awareness, and cognitive control. And these circuitries are, we'll just show you next. So these are neural circuitry basically involved in the SSD, and these connect the intercingulate cortex, insula, hypothalamic function, then amygdala, and the amplification is through this dorsal horn of the spinal cord. So the stimulus can be transmitted from here. It can go, or it can misfire, or it can be perceived in any circuitry, and symptom depends on that. Next. So these are the cortical areas that are involved in the SSD as per the PET studies, and these are basically anterior cingulate cortex, insula, and PCC, that is a posterior cingulate cortex, prefrontal cortex, and premotor and supplementary motor cortex. So the entire stimulation, the treatment depends upon which area is more activated. But no, that depends upon the large PET study, spectra study, and other database, so that we can have one common sort of circuitry that is involved, and that is the reason that we try to stimulate the insula or the dorsolateral prefrontal cortex, DMPFC. Next. So this already it is already presented. This paper is presented, and we found that response rate seems to be better with this, and we can explore that further. In fact, next. So the TMS has a definite role as a therapeutic intervention for certain clinical condition like depressive disorder, OCD, migraine, tinnitus also, negative symptoms schizophrenia also. And the research potential seems to be, have a good for any drug resistant clinical condition that we can think of, because we need to explore to develop a good treatment. And since it's an emerging field, the exploration of the to develop various protocols and knowledge sharing is very, very important, because some protocol works, some protocol does not work. And then it's good to share what works, what does not work, for the patient safety also, and good clinical outcome also. In SSD, what we feel that the role of TMS seems to be very, very promising, and we will see what outcome we get in our MD thesis that we are conducting in the department. Next. So this is our lab. We use navigation also. We have 100 Hz machine. We have 200 Hz machine. We have a deep concave coil. So we have entire range of the system from 50 Hz to 200 Hz. With neuro navigation and robotic handling also. And we conduct training every year, and now we're going to conduct training with the TMS periodically after every 4 months from October onwards. Next. Thank you very much for giving me the opportunity.
Thank you, sir. Thank you very much. It was so nice listening to your experience, and thank you very much for sharing your pearls of wisdom and motivating us to use rTMS more and in our for our patients' benefit. If there are any further questions from any of the participants, postgraduates, if you want any more clarifications, elaboration on certain points, you can please share your questions, or I will be handing over the mic to Anbaragan, sir.
Sir.
Hello.
Good evening, everybody.
Hi.
I'm Dr. Anbaragan. Good evening, everybody. In fact, we had a good scientific feast this afternoon, I would rather say. I especially thank our guest speaker from All India Institute of Medical Sciences, New Delhi, Professor Dr. Nand, for sharing his research experience in this ever-growing field of psychiatry, particularly in the neuromodulation therapy for psychiatric disorders. He had shown a novel area for our young psychiatrists to proceed with their researches in the days to come. Thank you very much, Dr. Nandakumar, sir.
Thank you for inviting me.
Yes, I thank Dr. Keerthana, postgraduate student from Trichy SRM Medical College and Research Center, for her wonderful presentation and the way she answered the certain questions with her little experience in this area of research. Thank you, Dr. Keerthana.
Thank you, sir. Thank you.
We also thank all the postgraduate students who were part of this discussion and put their thoughts into valuable questions. We really appreciate your participation in this RCBC program organized by IPS Tamil Nadu chapter. I thank the organizers who are part of the IPS Tamil Nadu chapter and the entire Tamil Nadu IPS team for being backbone of this program. We are also pleased to thank the East West Pharma for their support to run this program successfully for years together. Thank you, one and all. With this, I think we shall wind this session. Meet you all again during our next month RCBC journey. Have a good day. Thank you to the organization.